Please welcome to the stage Dr. Rushika Fernandopulle.
Good afternoon, everyone. I'm Rushika Fernandopulle. It's such a pleasure to be with you. A pleasure to be here at the Hint Summit. I wish I was here in person and with all of you, but this is the best we can do. So glad to share. What I wanted to do today is really talk a bit about my experience with DPC. And it's actually a really long experience. Let me get my slides fired up here. So thank you all very much for having me again. So my name is Rushika Fernandopulle, and I'm a primary care doc. And about 16 years ago, probably like many of you out there, I was sitting in my practice and realized that this was not working. I actually remember it really clearly. It was a February day. I'm in Boston, and I was working at an academic health center in a typical sort of practice. I had 37 patients booked. They all showed up. I had barely enough time to, go to the bathroom, let alone have lunch. And they put a new electronic health record in, which is awful. You do all these points and clicks to get your RVUs, and you get yelled at if you didn't. So I couldn't finish my notes during each visit, so I had to keep a pad of paper and scrawl things on it. Then I had to stay for 2 hours after work every day while my family was having dinner again without me, to try and type these in and remember and read my handwriting and remember to put this stuff in. And I had a colleague sitting next to me that day. And I remember she looked at me and she was doing the same thing. And she said, Rushika, every day I lose a little piece of my soul. Every day I lose a little piece of my soul. We went through so much training. People come to us with so many problems and we can help them. But in the current system of primary care, this gerbil wheel, I can't do it. And this is the key. And not only is it not getting better, it's getting worse. And that's when I decided I can't spend my career doing this. We need a different vision of primary care, and we need to start over. And so I was, did something crazy at the time, along with a handful of other docs, many of whom you probably know, Garrison up in Seattle, a guy named Chuck Kylo in Portland, Oregon, a guy named Alan Dappin in Washington, D.C. All of us sort of independently as docs just said, we're fed up with the current model. We want to start something different. Core to what's wrong with healthcare is that it's transactional. It's document, code, bill, next. It's turned into a series of transactions. We don't serve patients anymore. We serve whoever signs their check, which is a health plan. We need to change that. So I said, I'm a doc. I can build a practice, and we're just going to ask our patients to pay for it and keep these insurers away. So I started a little practice called Renaissance Health. You see here a little logo. Myself, I had a couple partners, and we said, we're just going to deliver care the way we think it ought to be, and build it on relationships and not transactions. And let's just get on with it and figure this out. And we simply told patients, and this was radical at the time, we're not going to bill your insurance. But look, if everyone paid us and we sort of back of the envelope at the time, this was 16 years ago, remember, about $40 a month, we'll break even. And we had this sort of crazy model where, if you're too poor to afford it, pay us less. And if you're rich, pay us more. And then we had another crazy thing, because I said, if you're a young person, thinking they probably couldn't afford it and we wouldn't have to serve them as much. If you were a young person, which was defined as being 35 or younger, because I was 35, so I had to be young, it's $20 a month. And let's just get on with it. And this sort of crazy model worked. People were paying us $20, $40, $60, $80 a month, and we got on with it. We developed a whole lot of great things. While we did that, we developed a position we called a clinical partner, now called a health coach, sort of a person who could help people engage with patients. And one of our insights was that person, the only thing they needed was empathy, being able to connect to another human being. We didn't need any medical training. We could teach any of that. And by the way, Kelly, the woman pictured in the slide, was our first health coach. And we actually met Kelly, a funny story, at Home Depot. We were at Home Depot buying paint to paint the walls of our practice. And we were having, one of my partners, Pranav, and I were having this conversation about we need to find someone who can help patients execute on their plans. As doctors, it's all well and good. We tell people what to do, but they need a human being with empathy. And I said, all they need to be is have a great personality. And he said, well, what about her? Kelly at the paint counter at Home Depot. And I thought, well, why don't we ask her? So I said, Kelly, do you like your job? She said, well, I like people. I said, well, do you like paint? She said, I don't particularly like paint. She said, well, I got a better job for you. Here's my card. Call me. So we started this practice, and we learned a ton in those early days of how to build DPC and what it was. Now, unfortunately, the powers that be in Boston didn't like it. Garrison in Seattle faced a similar sort of backlash. We had, the papers wrote us up a bit when doctors do the right thing. Patients started signing up. There was no hint health, so we had to figure all this stuff out ourselves. But then people started getting upset. The powers that be in Boston started saying, people might think you're working for the patients and not for me. You're raising expectations. You're making other practices look bad. Do you understand this could upset the status quo? But a couple of the hospitals kicked us out and took away our privileges. One of the big health plans, wouldn't let us sort of even send people to specialists, even though we weren't billing them anything. So we decided that we needed to think about this and point and pivot. And we made the transition that I think a number of DPC practices are doing now and saying, wait a second, who would benefit from this other than the patients? And the proposition was that if you do this sort of DPC and actually focus on primary care, that what we do is not only better experience and better health, but we would lower utilization downstream, would keep people out of the hospital and the ER. And we said, let's do that. So we ended up through an intermediary, guy named Arnie Milstein at a company called Mercer, selling this idea to the Boeing company. And so we went to Boeing and we said, look, you're taking care of all these people. You care about their health. Will you let us do essentially DPC for your employees? And so we worked actually through 3 of their big health systems, Everett Clinic, Virginia Mason, and the Valley Medical Center, to build these DPC practices where instead of the patient paying this fee, Boeing would pay the fee as a per person per month to take care of it and do all the things we do in DPC, which is emailing and texting patients and being proactive and, again, relational and not transactional. It worked incredibly well, by the way. This is some data that Arnie published in Health Affairs. We lowered the total cost of care by 20%, 20%. That's a huge number. Better physical and mental health functioning. Patients felt better about they got their care as soon as they needed. What's interesting is this last stat, which is productivity. We asked people, how many days did you miss from work because you were sick? And we dropped absenteeism by 56%. And what's really interesting is Boeing, actually, when we presented this to them, they're like, whoa, like we actually don't care about this healthcare cost thing, but if you can keep these people on the line and keep them rolling out these planes, like that we're willing to pay for. Right. So I think we were one of the first people to sort of do this with employers and then actually have independent academics show some of this data that the impact of DPC can really make a big difference. We were then asked by the casino workers in Atlantic City to do this. And why do they care? What happens in Atlantic City is the casino workers, the union, they negotiated total compensation, from the union, from the employers. And so there was a zero-sum game set up between wages and benefits. And I think you will probably heard Dave Chase talk about this. It still is true for everyone, but they realized it, that if healthcare costs go up, wages would go down. So let's actually lower healthcare costs. So they had us, again, work with Atlanticare to do a DPC practice for the casino workers union, the hotel workers, maids, etc. So we built this in Atlantic City. And you see a picture of we huddle every morning where we get together and we talk about the patients and did that. And again, we showed sort of huge drops in utilization, better health. People liked it better. What's really interesting is for 7 years, the union couldn't give people a raise because healthcare costs kept going up. We put this practice in. For the first time, they actually were able to give everyone in the union a 50-cent an hour raise. First time they actually raised wages because we kept a cap on healthcare costs by doing primary care right, which was really powerful. Atul Gawande, the New Yorker writer, wrote a nice article about it. It's called The Hotspotters. This is a picture of it. I think it was still maybe his most well-read New Yorker article. And so by now we were really saying we could do DPC, we could have employers or union trusts support this. Again, stick to the principle of DPC. Don't do fee-for-service billing. Don't be transactional. Allow us to do it, but just let someone else, pay the bill on behalf of the patients. I really wanted to scale this, right? So we've been doing this one at a time. That's all well and good. What I wanted to do, particularly after Atul wrote about us and there's a lot of sort of notoriety, is let's leverage this to try and scale it. Let's try and scale it across the country. Let's try to do this at scale. And so we started Iora Health. Iora started about 10 years ago. This is a picture of a company when we had 200 people. We're at about 700 people now. And let's build a scalable model of DPC that really tries to transform the industry, right? Sort of kicks the industry in the behind. We ended up deciding to raise money, right? So, you have to be very careful about this because there are many people who go down this road and take money from the wrong investors. I think Q-Liance went down this road and had difficulty. We've been very careful about who it is that we take money from. Make sure we take money from people who are really focused on the mission about transforming healthcare, who are long-term thinking. We've raised about $350 million, sort of a staggering amount of money. We've convinced people that this is a good investment to really put money in and transform healthcare. What we tell them is this is the biggest business opportunity in the world. You should provide it. This gives us a buffer to be able to do a lot of things, including, I'll talk in a second about investing in IT and being able to grow. So our biggest investor is Temasek, the sovereign wealth fund from Singapore. They talk about 50-year time horizons, investing for their grandchildren. Cox Enterprises, a few other folks. By the way, they don't have control, right? They give us money, they share in the upside. We've been very careful to say that we control the company. Part of what we've done with that money is think about building our own IT platform. I think as much as, Hint has built a platform for the billing of this, we wanted to build a clinical platform that worked for us. The most EHRs were built around transactions and document coding and billing and generated these ludicrous visit notes trying to get a 99214 that got in the way. And so we sort of built our own, and it's sort of cloud native. It's in the cloud. It's easy to use, and it's built for us for DPC because I think the existing ones out there don't work. About 6 years ago, we made a transition. We still do a little bit of retail. We still work with the employers, but the next step in the evolution, where I think very few people have gone so far, is really going into Medicare, right? So who really benefits from this sort of intensive relationship-based primary care? It's older, sicker people. And where are the older, sicker people? Well, of course, they're in Medicare. So how do we do that, right? So we started by saying, let's actually work through, so we couldn't until recently, and I'll talk about in a second, work with regular Medicare because there are all these stupid rules. They make you bill fee for service. It's toxic, right? Fee for service is the wrong way to pay for primary care. Stop doing it. But we found is we can go to the Medicare Advantage insurers, people like Humana and United and WellCare, and convince them, given the experience we had with the employers and with the retail, is why don't you pay us a fixed amount and we'll take care of your Medicare Advantage patients. So we've been doing this now for about 6 years, first with Humana, but now with virtually all the big health plans. We've also now started to move from sort of DPC per se, which is where you get just the primary care capitation rate. By the way, it's about double typical primary care. The cap rates for Medicare patients are in the $120 PMPM range. And by the way, the patient doesn't pay any of it. So this allows us to go and serve even low-income people. This is sort of concierge care for free, as I call it. But we started moving to global risk. We're saying, we are so confident now that by doing better direct primary care, we will actually lower the cost of care that let us keep all of it, right? So what happens now is we get virtually all of the healthcare dollar. We get to choose how much we spend on primary care. We don't have to argue that with anyone. We don't have to submit claims for it. Now, when our patients go downstream to the hospital or the ER, those get debited from our service fund, but whatever's left, we get to keep. And this is just a couple of pictures of some of our practices. The top one is one in Atlanta. The bottom one is sort of a group. We do a lot of group activities, particularly for seniors. They work well. And it really works. So this is just a graphic showing a medical loss ratio. So medical loss ratio is essentially you take the premium that's being paid by the government from the government to Humana, and what percentage of that is covering total costs. For average practices, it's about 85%, and the health plan keeps the top 15. We're running, if you see this, Iora wide, in the year one, the first year we get patients, we're running at about 85%. And again, the health plan keeps the first 15, so we're sort of breaking even. And it takes a little more the first year you meet people, all of to get to know them, to keep them on the straight and narrow, et cetera. The second year, we're down at 72. By year 3 of having a patient, we're in the mid-60s. That's a big gap. The gap between 85 and 66 is about 20 percentage points of total spend. That's about $200 per person per month of free cash flow going to primary care. That's a game changer, right, to do that. You see, we're doing that in Georgia and Tucson and Phoenix and Washington. Every market, we're running a similar pattern of, I think you all know this. I need to convince you of this, that better primary care, the way we do it in direct primary care, leads to these dramatic outcomes. The difference is we now get to keep that. COVID has shown that this model is the only thing to do, right? I think, there are all these things about people saying, oh, we've got a foot in the canoe and the foot in the dock. I don't know if we should do fee for service or do these sorts of other payment models. My point is the dock is on fire. COVID has shown that fee for service models do not work. You're at huge risk when things like COVID happen. Our revenue didn't change one iota, as did any of yours, right? As when COVID hit. So it's exactly the right thing to do. And we're also able to do the right thing. So this is an interesting graph. It shows our encounters per week across our practices by modalities. You notice from January to March, the purple is in-person visits. We were doing largely in-person visits with a bit of telephone calls and a lot of email and texting, but the synchronous visits were largely in person. And then the middle of March, I think it's the weekend of March 14th, it fell off a cliff, right? We decided that COVID was a real thing. We had to shut our practices down as much as we could to keep our patients and our staff safe. We kept all of them open because we should be there if they needed us, but we dropped to only 8% visit volume. The second thing you notice is the green. The green are telephone calls. When we dropped the visits, we hugely picked up our phone calls. And these were almost always outbound phone calls. We thought we had to reach out to every one of our patients and let them know that COVID's around, it's dangerous. If your red state governor may tell you should go to the tattoo parlor on the beach, he doesn't mean you. Right? You should stay home. You should be safe. Do you need food? Do you need medicine? We're here for you if you need us 24/7. Our COVID rate, by the way, is less than half of the national rate. We have, out of 40,000 patients, less than 300 have gotten COVID since the beginning of the epidemic. And these are largely old, sick people. It works, right? If we as primary care doctors, by the way, it's a shame. Less than 11% of Americans have said their primary care doctor has told them one word about what they should do about COVID. That's a travesty in sort of a huge health crisis that primary care doctors are not able to do that, and we can, right? The third thing you notice, right, so we picked up a ton of phone calls. The blue is video. We said we need to start doing this stuff by video. If we're not going to be able to see people in person, video is so much a better way to engage with people, build a relationship, etc. So we picked up in a ton of video. And right now, the fourth thing to notice is a lot of people tried to swing back as much as they could to in person. We said that's not the right idea. There's still COVID out there. And by the way, there's a set of things that are better done in person. So by all means, we should do it in person. And that's the purple. You notice the purple is about 40% of our encounters now. There's a set of things which are just as well done by video, maybe better done by video, particularly with COVID, and maybe regardless of COVID, it's more convenient. We should do it by video, about 40% by video, and about 20% by phone when people either can't or don't need to do it by video. So we're at this 40-40-20 mix, and I think that works really well. So, DPC is built for this. So this is Iora today. We have 48 practices across the country, about 600 employees, 35,000 patients. We're sort of coast to coast. The two gold stars, the new markets we did in North Carolina and in Houston. This works, right? This is, I think, one of the potential futures of DPC. And just to close on, really, I think what we're all doing. This is what's so profound, right? So in the typical world where we're paying fee for service, doctors are getting only 5% of total healthcare spend into primary care. We end up doing a crappy job like I did in my old practice at Mass General. So what happens? People go downstream. They go to the hospital and the ER when they don't need to. That increases healthcare costs. What do the payers do when healthcare costs go up? They lower the payment rates. Now we have even less time to see patients. We all know typical primary care is in that downward spiral. And what we do, all of us, is we provide really robust primary care, double down on the amount going into primary care, do the right thing like CP by video, reach out proactively, all the things we do in direct primary care. That decreases downstream spend, keeps people out of the hospital and the ER. We have great data about that. That decreases costs. We can capture that cost and then put more money into primary care. Right now, the wheel turns the other way. So I hope this was at least interesting, one perspective on sort of the evolution, at least, of Iora over the last 16 years, Renaissance in Iora. I think it's sort of one direction for some part of the DPC movement. We are hugely supportive of the movement. I think I missed the days when we had one practice and were just opening the shingle and taking people. I think there's something great about that. We are doing this at a different level. I think there are places in the business model for working with employers, and I think Medicare is sort of the next frontier. And I think we have a great future with the movement. So thank you very much. Love to take questions.
Thanks, Rushika. We actually have a bunch of questions, so I'm going to just go through a few of them. But first of all, thanks for being here and sharing your journey and what you've learned along the way. It's a real inspiration. So first question, what would you advise are the priorities for smaller practices looking to scale?
Okay, great question. So I think at root, we should all remember we are service businesses, right? And I think we're doing exactly the right thing by serving our customers, right? So I think healthcare is very confused as to who its customer is. Is it the insurer? Is it the employer? You know, we have been firm at the DPC practice, even if we're going to work through an employer, through Medicare, through a plan, our customer is the patient. And there's a period at the end of that sentence. So I think we all need to remember that. And how do we provide sort of the best sort of service for patients? And I think the second piece is actually, the magic is not actually about attracting patients, but keeping patients, right? These models are all about retention. So to the extent that we can provide ways to serve the patients better, we will keep them better. That will help us grow. The cheapest way to add a new patient is don't lose one. And I think that will help grow the movement and grow small practices. So focus on retention, focus on the customer, and don't let the rest of the noise, fool you.
Great. So many practices, many DPC practices avoid Medicare. Do you see CMS becoming more supportive of direct payment models that don't overly burden the practice?
Yeah, it's a great question. So we, for much of our history, never worked with Medicare because they're a pain in the ass, right? And there are all sorts of rules. You've got to opt out, and So I think working on those terms is not a good idea. So I agree. We and other people have been working really hard to advocate with Medicare to figure out how to change the rules, right? So we can work with them or somehow in a different way. And again, my point is that old people need this, right? Our seniors need this model of care. If anyone needs it, seniors. So again, going through Medicare Advantage insurers is a good way to do it because they have the prerogative to do anything. We don't have to submit the codes or anything. So that's one route. There are some new programs coming out through CMMI, as I'm sure you know, Zach, called direct contracting. There are a few others. Some are designed well, some are designed poorly, which allow people to potentially work with Medicare without a lot of that overhead. It's still really early. These programs are still sort of in about a bunch of flux. I think at the moment, bigger people like us who've got a little bit of capital, a little bit of expertise are working with them. But I think the goal is to work out the kinks and eventually hopefully create some programs that let CMS work with smaller practices. It'll happen. The government moves slowly, but I think the direction is going in the right way. By the way, this has huge bipartisan support. We've done a bunch of work, on the Hill with this, and and we had a bill recently that was co-sponsored by Senator Cassidy, who's a very right-wing Republican, a doc, by the way, from Louisiana, and Patty Murray, who's a very left-wing Democrat from the state of Washington, and they both co-sponsored this, right? So I think there's some strong support in Washington on both sides of the aisle, and so we'll get this. It just moves slowly.
That's great. Another quick one here. How do you serve Medicare patients through an Advantage plan while opted out, or are you not opted out?
Yeah, so we're actually opted in. So we are not opted out. So we're opted in on our patients, but are able to then work with the Advantage plan and be a network, but then not have to bill or pay for fee for service. Yes.
Great. A couple of tactical ones here. How can you promise 24/7 care without being burnt out?
We think that the right thing to do for patients, so again, the question we ask is, what does the patient want and need? If you're a patient, I think you want to be able to access your doc 24/7. So we take call, right, 24/7. It's one of our docs takes call 24/7. Patients in general don't abuse it. People I think are afraid when they do that. And our patients are very respectful and they don't. I just took call for one of our practices, one of our busier practices, and I got 5 calls all week. And only one of them was late at night. All the others were during reasonable hours, right? So I think the demand is actually not that huge, particularly at the panel sizes we all run. The second is we all know there's a tiny number of patients who probably want to reach us a lot. So what we do is we have sort of Friday afternoon call lists as we reach out to them. Hey, just want to check in. Anything you need for the weekend? Great, we're here. But if you don't need us, we'll see you on Monday, right? So I think doing a little proactive management helps a little bit, but it's never been a problem offering our patients 24/7, phone or video access to us. And we take turns, the docs in a market take turns on a weekly basis taking that call. And it's really not a big burden.
Yeah, and actually that's a fairly consistent feedback, Rushika, when we talk to our clients as well, is that as a general rule, patients really kind of honor the commitment that you're as a provider, you're sort of giving to them that you are available, and they don't abuse it because they recognize that you also have a life.
Yeah.
And so, yeah, that's really consistent feedback. So where can we get data on reduction of downstream costs?
Yeah, no, it's a great question. So we, so there, so it takes a little wherewithal to get the claims data. When we started our first practice in Arlington, in Boston, we really wanted the data to be able to show people, and the health plans refused to give it to us, right? Because, I won't get into that, but they refused. We eventually got to enough. So when we started working with the employers, right? So when I asked Blue Cross for the data, they give me every excuse. When Boeing asked for the data, they say, yes, sir, where do I send the data, right? And so really we had to wait till we were working with the employers, and we got the employers to ask for the data, or to get their consultants to ask for the data, right? What's interesting on the Medicare side is, the Medicare data is actually available through a thing called Blue Button. So now with Medicare, we can just pull down the data. When we work with our health plan, so we work with, Humana and United, one of the things we insist on the contract is we want all the claims data for, going back 2 years, so we can show the impact of this stuff. So again, it's not, and again, we're not like an individual practice. We've sort of built the wherewithal to do this, but I think it's really important for us, or at least some of us, to be able to document that, by doing the sort of direct primary care, and again, the fundamental premise, all of us, if you look at the fees we charge, it's essentially double typical primary care, right? So 80-ish bucks PMPM, which is probably the average right now, you tell me, is probably about the average DPC. And, typical primary care for commercial population is about 40. And so we're asking people to pay double what typical primary care is. Now, remember, primary care is only 5% of healthcare spend. All we have to do is reduce total healthcare spend by 5% to make this worthwhile in the big scheme of things. And so that's what we do. And we're dropping it by 20 or 30%, right? So I think that's great. A few of us need to show it. I think increasingly there's people are getting it, right? And we don't need to keep showing it.
Yeah, that's great. So a couple more questions here before we hit the time limit. First is, what is a standard panel size for the Iora practices with team-based care?
Yeah, so our panel size is about 600 per doc. Right now, our team is pretty robust. At the doc, there's 2 or 3 health coaches. There's a OA across a couple teams. We have a nurse and a behavioralist. But that team, basically per doc, is about 600 patients. It's graded by how sick people are, by the way. So if you take on a sicker panel, and we have a thing called a worry score, it's fewer. So we have some doctors running panels of 400 or 500. We have others who have largely healthy panels, and they're running higher, 700, 800. But 600 is if you want to pick a number.
It's great. And I think this is probably our last question. So if your question got missed, my apologies. How do you navigate potential pressures on your care decisions from Medicare Advantage carriers? It's a good one.
It is. So the good news, so part of the good news about taking on the total risk of care is no longer their problem. It's our money. So they actually don't care anymore. They're just taking a percentage off the top. It's all our money. So it's really us deciding what we want to do. And we have a deep faith that if we do the right primary care, the other stuff will follow, right? I think, again, I said this before, we have to work for our patients with a period at the end of that sentence. We can't work for the insurer. We can't work for the health system. That will lead to badness. So we should work for our patients and have a deep faith that if we do the right thing with primary care, and there's tons of data that this works, we will make an impact on the total healthcare costs. So we try to set it up where we will not be influenced for that.
Yeah. Hey, fantastic. Thanks so much, Rushika, for joining us. And it's great to see you and hear from you directly. Thanks so much.
Next time in person.